For centuries together, dental surgeons are treating patients. Our primary goal is to restore the lost tooth structure or restore the lost teeth. While restoring the lost tooth structure, amalgam was extensively used. It still is used, and then it got replaced with composite resins. So, we are using composite resins on day-to-day basis and trying to restore the lost tooth structure and try and give it the form what it had originally. When the tooth is badly mutilated, we still go ahead and try saving the tooth by treating it endodontically. Once the endodontic treatment is over, we need to give some form to the tooth so that the occlusion gets restored back and the tooth is secure. So, we offer porcelain fused to metal crowns. We also have possibility of metal-free crowns. Initially, it was restricted only to the anterior region, but now we are getting better materials, and with these materials like zirconia, we can restore even posterior teeth with crowns which are metal free. Beyond this, what treatments are offered in a clinic are extraction. Extractions of teeth are done only when nothing else can save the tooth. This should be our last modality of treatment. And as extractions are done, our second job starts, and that job is of restoring lost teeth. It could be partial loss, as you are seeing in this picture, or it could be complete loss, making that patient edentulous. Now, when this happens, we have different ways of offering the restorations, but while doing so, we cannot ignore the expectations of patient. So, what are those? All the patients, irrespective of their age, want the restoration or the processes which is aesthetically pleasing. They also demand satisfactory function of mastication as well as phonetics to be stable, retentive, and given a choice, fixed. Now, while giving the conventional processes, we had complete dentures in a completely edentulous patients, and these complete denture patients used to wear these dentures for some period of time and eventually land in a situation, especially a case which I am showing you here is of a 51-year-old female patient. She is controlled diabetic. She has fixed prosthesis in upper jaw supported by 6 teeth. Lower jaw, as you can see in the picture, is edentulous, and she was wearing conventional removable complete denture in lower jaw for past 10 years. Now, at 51, she is still young. She complains that the dentures are not retentive anymore, and all of us can see in the photograph that all the muscles are pulling the soft tissue. There is hardly any vestibular depth, and the mucogingival junction looks very close to the crest, obviously because the bone has resorbed. There are several reasons for this bone resorption. The first is her biomechanics. Upper jaw has fixed teeth, lower jaw has removable processes. She is diabetic. Diabetic is known to cause secondary osteoporosis. So, her bones are suffering. She is 51, so she is in a postmenopausal period of her life. That also can aggravate the physiologic osteoporosis. So, there are several reasons for this lady to suffer. Now, what answer do we have at age of 51 when she says the dentures are not retentive, upper teeth are fine, they are fixed on support of natural teeth. She is unable to chew. She says, I have to just gulp rice every day, and being diabetic, I am not supposed to be eating rice. So, why are we asking these patients to face this situation? Why can't we offer them implants at age of 41? Or the patients who have lost teeth in short span, few teeth are lost. We give them partial dentures. They could be metal dentures, cast partial dentures, they could be acrylic dentures. How many of them really like it? Most of them refuse it. Most of them want fixed prostheses. So, when we give them fixed prostheses, at some point of time in their life they come back. It could be 5 years, it could be 10 years, 20 years, but some point of time they really do come back. And when they come back, there is a huge compromise. This photograph shows you a photograph of a young lady, she was 32. She was complaining of fixed prosthesis which was mobile now. She is a lawyer, so she says, I need these teeth, and when I speak, now they have started moving, so please do something. This prosthesis was given to her at age of 21. I understand she was young then, but she is still young at 32. Her professional demands are high. So, when we tried checking that fixed bridge that was gone wrong, under the bridge what was seen was nothing but huge compromise. When we look at this compromise, we can honestly agree on one point, that this compromise is maybe partly due to her hygiene, but we are also responsible for it. It is iatrogenic. For a single lost central incisor in an accident, we could have given her one implant and not compromised 4 more teeth. Today at 32, 4 teeth are in a compromised state, and her demands are still high, and she has a long way to go. When we look at such patients who have received bridges which are connecting canine to the last molar, these patients continue to use these prostheses till one night they start getting pain. Next day morning, the first thing they would do is rush